everyone's here, I'll hand over to, again, Professors Haxby Abbott and Anne Smith to chair the next session. Please take it away.
Wonderful, thank you. This meeting is the forum debate. We will address the question, approaching non-surgical care through group therapy is most effective. For this meeting, we have speakers for the affirmative, and that is Christian from the La Trobe University in Melbourne, and we have JP Caneiro in the negative. And we've had some experience, some technical difficulties there for a moment back, and so we're just getting ourselves back on track. But what we have today is a debate amongst two giants of the mid-career field in physiotherapy for osteoarthritis, going head to head in this great debating chamber. This debating chamber I'm standing in right now, you can see behind me, is the Oxford Union debating table at Oxford University, which has hosted some fantastic debates throughout the 19th century. And we are hoping that today's debate will be of that standard. Alternatively, we might find that it is as a debate better suited to one of the great debating chambers of the late 20th century. And so we'll see how it goes. But to lead off, am I right, Dr. Barton, that the side for the affirmative is to begin? Is that correct?
Yeah, that is correct. JP's okay. But JP's controlling my slides, so I'm not sure if that's going to be very fair, JP.
All right. So first of all, I'll lay down the agenda and the rules for the debate. First of all, the side for the affirmative will have 5 minutes to present their argument, and then the side for the negative will have 5 minutes to present their argument. Then each side will have 3 minutes to pose rebuttals, and then we shall have a question and answer session. I'm going to challenge the audience today to ask questions in which they challenge each of the debaters on the basis of the evidence for their arguments. And Professor Anne Smith of Curtin University, who is co-hosting here today, and myself will be taking scores on their answers to your questions, on the evidence backing up their arguments. And then at the end, we'll have a show of hands from the audience using the raise my hand feature in Zoom, if it's available to you, and Professor Smith and I will also score the debaters out of 10. So Dr. Christian Barton, known as the communicator. Christian the communicator Barton will lead out, and his opponent, JP the dapper man Caneiro, known throughout the streets of Perth as GQ Caneiro, will be presenting to the negative, following Christian the communicator Barton in the affirmative. Go ahead, Dr. Barton.
Can you please share my slide, JP?
I'll have a think about it. Hang on.
And while you're doing that, I shall sit back and enjoy this.
I like Haxby's really trying to get some excitement here.
Can you see that, Christian?
Yeah, can you please progress to the next slide, JP?
Sure. Whoops. There you go.
So if we start, humans are very, very social beings. We seek support, we seek guidance, we seek assistance from friends, family, colleagues, and when we seek healthcare, we seek support from others. This support can come not just from health professionals, but also from our peers. And this is a really important aspect of group exercise or group therapy. seeking help with support from our peers allows us to share experiences, allows us to not feel alone, allows us to talk to others about their experiences. We can learn tips and tricks from others. It gives us a sense of community that we're not alone in this fight, in this battle. And that's a really important thing for any group therapy, and in particular for people with knee osteoarthritis. An individual will have knowledge, they'll have skills, they'll have attitudes, and they'll have beliefs. And many of these things will potentially contribute to their pain and disability and their loss of quality of life. By experiencing rehabilitation or exercise with others, we can share our knowledge, we can share our skills, and we can bring things forward together, and we can improve our lives and our quality of lives. We can also develop a social network. And so one of the key things that I see in a program that we implement across Australia with GLAD is not only does group exercise help these people, and I'll come to that in a minute, but it also helps them build their own sense of community and their own community to continue an active management approach and continue support networks. We see people set up their own Zoom exercise classes in the context of a pandemic so they can connect. We see people set up their own exercise classes at the gym together and go along there. We see people set up and join community dance classes. And it's this group therapy that allows that to happen. We even see people simply going for a cup of coffee after their group therapy to continue to learn, consolidate the education that's provided within GLAD. Next slide, please, JP. Group therapy can inspire. We see many people who are reluctant within our GLAD sessions to get on and off the floor, but they see the 80-year-old across the other side of the room, and they see them and they see their progress while they're in the class, and they see them getting on and off the floor, and they say, hey, well, if they can do that, I can too. They see people who go back to running, people who go back to playing with their grandchildren on the floor, and they get inspired by that as well. And they say, hey, this is for me too. I can really get my quality of life back. And I put a patient case study here, which was published by Millie Bell, a PhD student you've heard from. They see other people who are dead set certain that they need surgery. They go through the experience of getting quality education and exercise together. They share that experience, and they share, importantly, the power of education and exercise, and the experience of seeing others really brings them on board and brings them forward to progress through what should be quality first line care. Next slide, please, JP. And if we look to the evidence, a great systematic review published by Mary O'Keefe and also involving Kieran O'Sullivan, who we heard from earlier, when we compare group therapy to individual physiotherapy, we see better outcomes as well, or at least comparable outcomes. If we look at disability in the medium-term follow-up and the longer-term follow-up, you'll see that it actually favours group therapy when we look at the data across a whole range of different studies. And the reason, I suspect, is probably because of that social support. Remember, humans are social beings. The other thing about group therapy is it costs less. So it allows us as therapists to spend more time with people, more time supporting their education journey, more time supporting their exercise journey. Next slide, please, JP. And we know group therapy for osteoarthritis works in the real world. So this was the first paper published on GLAD, which involves 2 group education sessions, 12 group supervised exercise sessions over 6 weeks. We see clinically meaningful improvements in pain, clinically meaningful improvements in function, and importantly, the longer term outcomes are sustained, which we don't always see with exercise and education, particularly delivered in individual settings. We see reductions in sick leave, medication intake, so that shared experience of reducing people's disability is probably very powerful in that sense. Next slide, please, JP. And most importantly, the majority of people tuning in today are from Australia, and we see that group therapy in Australia works. I challenged my opponent, JP, to show me a data registry that has more than 2,000 patients who have got positive outcomes. So we have 3 in 4 people with clinically meaningful improvements in pain and quality of life. Of those who desire surgery at baseline who have participated in this group education and exercise program, 3/4 of them have not had surgery at 12 months and no longer desire that surgery. This is really powerful data that not only shows that there's RCT evidence for group exercise and education therapy, but actually we have real world outcomes that show the positive value of this group-based care. Thank you.
Well done, Christian. That was a very good argument. And I think if we go back to basics and just remind ourselves of what are the factors that influence pain. And we know that factors such as the structure can definitely influence someone's pain experience. we know that the physical activity levels can influence a person's pain experience, and their level of muscle strength, and of course their biomechanics. So these are three factors that are often easily considered when we think of exercise therapy, especially in a group environment. We can look at someone's scans, we can look at how active they are, we can look at the levels of strength, and put them in a group session and progress their activity levels and take them through an exercise program. However, one of the things that we need to remember is that pain is not only influenced by these three factors. There are several other factors that can influence someone's experience of pain. You know, their beliefs about the reasons as to why they have pain, the cause of their pain, and the potential consequences of having that pain. Their overall health, we know that there's significant evidence around the fact that if you're carrying more weight around your belly, it can influence your tissue sensitivity. Your lifestyle factors such as poor sleep, which is a highly pro-inflammatory factor. Social circumstances. You mentioned the socialization in group therapy as being an important factor, and it is. But some people are social phobics. Some people don't like to be in groups, and also the other factors such as body confidence and their fear levels. So we know from the literature that several of these factors can interplay to lead to an outcome of tissue sensitivity and pain. And what that leads us to understand is that pain experience is very unique and associated with this interplay of multiple factors. And therefore, there's a need for a person-centered approach. And what patients would like to know when they come to see us is that they want to have a good understanding of their pain in their particular context. They want to develop individually tailored strategies to manage their pain. And they want to have tailored support to achieve their individual goals. So as we can see, it's very driven by the person, their current context, their social circumstances, their own understanding of that problem. So if we look at these two cases here, so let's consider we have two patients that come into the clinic with knee OA. And if we, after doing an interview and after examining this patient, in an individual basis, we can come up with this radar graph, which highlights some of the key components that may be contributing to this person's pain presentation. And they are alluding to all the factors that I presented on the slide before. So for this particular gentleman here on the left, cognitive factors, physical characteristics, and his structure seem to be some of the key factors that need to be addressed in order to have an impact in this person's pain and disability. If we look at this other gentleman, however, his pain experience is completely different. You know, he's scoring much higher in cognitive and emotional factors. His health seems to be a problem. He's way more sensitized than the patient on the left. He has some social contributors to his presentation. And these may be that he's feeling socially isolated or he's caring for someone in his household. His lifestyle seems to be a problem. But his structure does not seem to be a big factor. And his physical factors, they do contribute, but to a lesser extent to the other patient. So what this is demonstrating to us is that there's a clear need for an individualized management of these two patients. And that is something that we need to consider when we're making these choices about sending people on a group therapy pathway, or do they need individualized care? And you presented this great work, as you said, Christian, that group therapy costs less and works better. But hang on a second, let's have a look at that graph and look at what does individualized physiotherapy meant for the studies that were collected in the systematic review. And the first thing that we know is that 12 of the 14 studies included passive therapies. So non-exercise-based therapy were put together. And that's probably a reflection of what we have done to our profession. You know, if surgeons or GPs send patients to a physiotherapist, they may get electrotherapy, dry needling and taping on one hand, and they may get individualized care on the other hand. The other thing that we know is that the exercise was not individually tailored, and patients received the same dose and the type of exercise, which goes against some of the elements that you presented in the group therapy. And the individual needs were not considered in this situation. So clearly what we're seeing here is you're not comparing apples with apples. We are comparing in this study, which was well done. And these are all elements that were brought up in that discussion. So if we are to compare group therapy with individualized physiotherapy in the future, we need to be comparing good products of both modes of delivery. Thank you.
Thank you, Dr. Caneiro. That's wonderfully presented by both the affirmative and the negative to the moot. Approaching non-surgical care through group therapy is most effective. Now we're going to move to the rebuttal phase. In these rebuttals, I'm going to ask each participant to speak for 3 minutes. After 30 seconds, I'll give a single ding. And then at the end of 3 minutes, I'll ask for you to cease your answer, and then we'll move on to the second speaker. So Dr. Barton, do you need any slides for preparation, or are you ready to go?
I have my next slide, which I'll move to shortly, and I need just 90 seconds, Haxby. First point to make from JP's slides, he put up a beautiful wheel of lots of different factors that relate to osteoarthritis. All of these can begin to be addressed in group therapy. In fact, during the GLAD program, each of these factors is discussed during group sessions. Patients share their beliefs and their ideas and their feelings around these things. And in fact, it gives them permission to talk about the struggles with weight management, the struggles they might have with social isolation, the struggles they might have with fearing damaging their knee, and that allows them to support each other. So we can certainly address these factors in group therapy. The second slide that Jay put up was an N of 2. I saw 2 participants in there, 2 very discrete participants, but I failed to see that that is a huge problem across the board. I showed you a slide of nearly 2,000 participants that would benefit from group therapy. I don't think I need to go further than that. Finally, the point I'd like to make is we know from data that's been implemented into cost modelling that if we provide group therapy in Australia to all people who might go on to have joint replacement surgery for their knee, that based on this data, we could save somewhere between $600 and $700 million per year using group therapy, and that speaks to the cost effectiveness of it. Now, if I put my more conservative hat on and we say more of these people, so rather than say 2/3 avoiding surgery for at least 2 years, which is what the data suggests, and let's just call it 1/3 would avoid surgery in the longer term, and certainly in the modelling would indicate that, it's probably going to save our health system more than $300 million per year. If JP can show me data that individualized care can do the same, then I will eat my hat. Thank you.
Thank you, Dr. Barton. Now, JP, do you wish to put up a backing slide before you present your rebuttal?
Yes, absolutely. So you're correct, Christian, and you present some good evidence around this. And you also presented that in GLAD Australia, you have 3 in 4 people that have meaningful improvement in pain and avoid surgery. But that means that 1 in 4 people are still complaining of knee pain, and they're still deciding to go for surgery and seeing that as their only option. So what happened with those people? What are the options do they have? If GLAD is presented as potentially one of the solutions and group therapy is the way of going forward, once they finish that program and they did not respond to that program, what happens to them? What are the options that they have? And one of the things that we know, and that's the beautiful work from our moderator, where they did a trial comparing usual care, exercise therapy plus usual care, manual therapy plus usual care, and combining the two. And what we can see, and if you follow the lighter blue, is that exercise therapy was in fact effective, and it was more effective, not only for health gains over 2 years of follow-up, but also cost effective for the person, for society, and for the health system. So we do have data. We don't have, and there's still, and I have to admit that we still have data to be further produced in terms of individualized care. And that is part of my role with Opus, is to come up with this potential alternative in providing individualized care for these patients as an option for surgery. The other thing too that we can remember is if we go back to that systematic review that you presented, Christian, and from Mary O'Keefe and herself has done a randomized control trial looking at group versus individualized physiotherapy for patients with back pain, where individualized physiotherapy presented some very positive results. So one of the things that we can see is that we do have evidence on management of osteoarthritis across the board. If patients are coming to see us for individualized physiotherapy, there is evidence for that. If they are coming for group physiotherapy, there is evidence for that. Even if they're seeing us over telehealth, there is evidence for that. So despite our debate, I guess what we get into the conclusion here is that we both have arguments towards group and individualized physiotherapy, and we both have good evidence to support these pathways. So perhaps what we're seeing is not a one-size-fits-all in one of these modes of delivery, but perhaps what we're seeing is that as clinicians, we have options. And most importantly, patients with osteoarthritis have options, and they can choose depending on their circumstances, depending on the part of the pathway in which they are, and also depending on their affordability, which unfortunately is coming down to the patients because we're not entirely supported by the health system in providing either of these modes. Thank you.
Thank you very much. Wonderfully presented, you two. And I've put up a poll on Hoover to request participation from those people watching on that platform. And we also have people participating on the Zoom platform. Those of you watching on Zoom, what I'd ask you to do is to indicate which of the two speakers you consider to be the winner of today's debate. First of all, can I please have votes? Raise your hand using the reactions tab at the bottom of your Zoom screen. Please raise your hand or press the clap applause button if you vote for the affirmative. All right, you've got 30 seconds to vote for the affirmative, either in the reactions tab in Zoom or in the poll in Hoover. Counting down. I'm counting them in Hoover. Professor Anne Smith is counting them in Zoom. Are you finished your count, Anne? Are you finished, Anne? Oh.
3 raised hands in Zoom at the moment.
Radio. All right, that's 3 in Zoom. And now,
I fear many people may not know how to vote.
Now, please cast your votes. Okay, we'll clear that. Now, please cast your votes if you consider the winner of the debate to be the JP Caneiro arguing for the negative. Votes for the negative. 30 seconds to vote.
On Zoom, we had 4 and 1. We had 5 votes.
Okay.
Yeah.
So, okay.
He's voted for himself.
I now have.
Take a point off of that. You can't vote for yourself, JP.
Okay. I'm ready to announce the winner. Will it be Christian the Communicator Barton or JP the Dapper Man Caneiro? One participant gets points off for blatantly trying to sway the judge by presenting the judge's data and for voting for himself. So I'm going to deduct 1 point for that. The winner is, some say he dreams in infographics. Dr. Christian Barton, 14 points to 0.
Oh, great.
Thank you for your...
One.
Clearly, Dr. Barton has marshaled the data to supremacy. And so thank you all for joining us today. I hope you enjoyed.
Before we finish, we have one conclusion slide, Haxby, that we'd like to just put up.
Okay, you've got 30 seconds.
Yeah. And I think we'll be staying in the same room for the next part of the session as well for the workshop.
Okay.
So we're all good.
Wonderful. Thank you to both. Please go ahead.
So I think everyone will probably realise there was a bit of orchestration there between JP and I, and we probably sit on the same page. So I guess to give everyone some take homes, which I think is really important, can you bring up our points, JP? So JP made this very nicely in the end of his rebuttal, is that actually evidence supports both, and that's a really important consideration. And ultimately what it comes down to is patient-centred care. So having the conversation with each individual person about what's going to work best for them. Are they going to participate in group? Do they need individualised care? You can individualize group sessions as well, and that's certainly a strong approach within a quality group exercise program, is tailoring the exercise program to each individual, but there are some limitations compared to particularly individualized care. Individualized management and support with, what are we trying to say here, JP? Individualized management and support with group.
Well, it means that we can individualize the management, and we can progress them to a group session if that's necessary.
Yeah.
So we saw a patient this morning that she's been struggling to work by herself, but having the group therapy is now an option for her, which she wasn't keen to do initially, but now she's interested because of that evidence around dose of exercise.
Yeah. And then I guess the other point, and this JP probably highlights an example there, you can start with one mode and move to the next. So some people might start with individualized care and move into group therapy. Other people might be doing group therapy, not responding, and move back into individualized care. And actually, you can plan to provide both from the beginning. And so a quality program, if you were to refer someone or start someone on a program that's available for group sessions like GLAD, you would still want to do individualized goal setting with them. You might still look at individualized sessions with those people to tailor their education and tailor their program to them, especially beyond that initial period. So I guess at the end of the day, JP and I probably agree with each other pretty strongly. And that is, there's really relevant and strong evidence and support for both options. And we really need to think about and go back to that second point, patient-centered care that we need to provide.
Yeah, and probably an important point to remember as well, Christian, is that to provide group therapy, physios will need a gym, but also in community centers, this could be definitely supported by the government. And I know you have some initiatives in Melbourne, which are great. So thank you very much for your attention.
Wonderful. Thank you to Christian Barton and JP Caneiro for an interesting, informative and entertaining debate. And thank you also to Professor Anne Smith for co-chairing the session. And we'll hand you over now to Sid for the next session.